Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. Welcome to today's episode of the Neuromodulation Podcast. Part 3 of this 3-part series brings together Dr. Christopher Honey and his patient, Larry, in a candid discussion about the clinician-patient relationship in the context of neuromodulation therapy for Parkinson's disease, specifically deep brain stimulation. Today, we'll discover the importance of patient education, the decision-making process, and the journey through pre- and post-operative care. This insightful conversation is going to highlight the collaborative nature of healthcare and offer guidance for both patients considering neuromodulation and physicians aiming to support their patients effectively. So to start, we have with us today Dr. Christopher Honey and Larry. Welcome to the show.
Thank you.
Thanks, Mandy.
So Larry, in our last episode that we did together, we learned about your neuromodulation journey a bit. In this episode, we really like to discuss your care experience along the way. How did you find yourself with Dr. Honey, and why did you feel confident in choosing Dr. Honey as your clinician?
Well, he was my only choice. In British Columbia, there was one surgeon that would do this operation. So I got in line 4 years ago when there was 100 deep pre-pandemic. And my neurologist said, let's just get you in line. It's a long line. By the time your name comes up, you'll probably want it. If not, just say you don't want it and move on. And by the time my name came up, I was more than ready for it.
And I recall you said it was 4 years that you waited.
4 years, which seems like a long time, but it went by fast.
So in that time, over 4 years, Dr. Honey, how many procedures would you say that you did?
Well, I'm over 1,000 now. So there's a good and bad about being the only surgeon providing the care for British Columbia. The bad is the patients don't have much choice. It's our team or nothing. But the good thing is we have a ton of volume. And so there are very few centers in the world that have done as many as we have. And right now I'm over 1,000 patients. And so like anything, the more you do, the better you get, right? And so at 1,000, we have seen, we think almost every possible potential complication, and we know how to avoid it. So we're doing about 70 a year. So in those 4 years, we would have done 240 people. Yeah.
Okay. And do you have any insight on how long the wait list is or how many people are around?
So we're trying to reduce it. We think if you're referred for DBS for your Parkinson's, we think you should be seen and operated on and ready to go within a year. Within 6 months would be even better, but probably realistically within a year, not 4 years. And so we're working hard to reduce that, although the demand continues to increase because the incidence of Parkinson's is going up and our population is aging as well. But just recently in British Columbia, we hired a second functional neurosurgeon, and we hope to really work on our wait list. The neurologist played the game a little bit, knowing that the wait list was 4 years. And so they often sent patients a little bit early, knowing that, hey, maybe by the time you get to see us, it's time for your surgery, maybe not. And so they were playing that a little bit. But the problem with that is that patients arrive and they're fine. They don't need surgery, and so they've taken up the time that we could have seen someone else. So I think ideally we'd like a referral to finished surgery within 1 year. And that's what we're aiming for.
Okay, so a patient like Larry comes into your office. Help me understand what you do to set expectations regarding the timeline and the procedure to help you decide.
Once you're in, it's quite quick. There's not a big wait list between seeing me and getting your surgery. That's a much shorter wait list than coming into the office. And so there aren't problems in terms of setting expectations for that.
And I'll tell you what he does is he sits down and he tells you exactly what he's going to do. Nurse Nancy then follows up and goes through every single detail that you could possibly imagine.
Yeah.
It blows your mind a bit, but
Well, the truth is that every single patient is slightly different, and no two are the same. And we are very good at certain symptoms, motor fluctuations, tremor, dyskinesias, but we are not very good at other symptoms, cognitive decline, depression, all the autonomic problems, balance issues. And so we really listen to the patient to find out what are their specific symptoms. And then we need to understand them as a human. Are those specific symptoms interfering with your life? So, for example, if someone has, let's say, God forbid, they've got bad cognitive decline from some aspect of their Parkinson's, and they have a tremor, and they come in, if I just focused on the tremor, I can get rid of their tremor, but their quality of life might not improve dramatically if they were badly demented or had problems with that, or if they had a bad depression, their quality of life probably wouldn't go up, even though I could nail their tremor. And so we really have to understand, what is it that is interfering with your quality of life? And there are some patients that are just perfect for surgery. And there are a lot of patients who I don't think they're going to have a significant improvement in their quality of life to warrant the potential risk of surgery.
Patient selection is something that comes up quite a bit in the neuromodulation space. Help me understand what makes a perfect candidate.
Yeah, if you're talking about deep brain stimulation for Parkinson's, a perfect candidate would be someone, for example, who had motor fluctuations. And when their pills kick in, when the dopamine in their pills get out of their stomach and into their blood and up to their brain, when their pills kick in, they're amazing. But unfortunately, it's a pill and it wears off. And let's say it wears off within 3 hours. And so every 3 hours, the patients are fluctuating with 2 hours of really good movement. It's hard for them to plan their life. And the beauty of the deep brain stimulation is that the benefits are very similar to the benefits that you see from the drugs, from the dopa. And so we can match their best on from drugs with our best on from DBS, but the DBS is on 24/7. And so they stay at that level of good functioning around the clock. We don't make them even better than they were on their meds, but we keep them at their best and they can have a more predictable life at that functional level. And so that would be a great patient.
He's being very humble. You do improve people's lives better than it was.
Yeah.
Yeah. Right now, my UPDRS score
Yeah.
is better than when I was first diagnosed with Parkinson's.
Well, we do spend a lot of time tempering expectations,
Yes, you do.
because a lot of patients have heard about good results from our team, and some patients arrive in the clinic and they are expecting their Parkinson's to be cured. And we're not curing their Parkinson's. We're treating some of their symptoms very, very well and other symptoms not so well. And if we've picked someone that has a lot of symptoms that we can treat, they're going to do very, very well.
So when Larry came into your office,
Yeah.
how optimal of a candidate was he?
They seem like a perfect for us. Yeah.
Every 2 hours, I
Yeah.
was taking pills. So
Yeah.
my cycle was, a
It's-
half hour to get on, and then an hour, and then a half hour to get off.
Yeah. And so what happens is, when you first have Parkinson's and you start your pills, you might take one pill 3 times a day, and the pills are lasting 8 hours. And then eventually the pills don't last as long and you start shortening your dosing interval. And so we've had patients dissolving their meds in water and sipping every half hour. So if that doesn't interfere with your quality of life, that's okay. But at that point, you're really struggling. And if someone is taking their meds every 2 hours, like Larry, that's really hard to plan your life,
Yeah, absolutely. So how much time did you two get to connect prior to the
Probably
surgery?
not as long as Larry would have liked.
No, we were together 25 minutes.
Yeah.
Visit with my wife, and
Yeah.
you sat down and you stayed until our questions were answered.
Yeah, and I've done that sort of spiel before. I know what they need to hear, and we've got everything else sort of written down on my website if they need to go and.
Why don't you tell them what their website is?
Yeah, so that's it's an educational website for patients, and it's drhoney.org. So it's drhoney.org, and everything I do is on that website, written for the layperson, written for the patient, and sort of written for medical students too, so that they can learn about these. And you would just click on Parkinson's or DBS, and that would have the cold, hard, black and white facts about the surgery.
25 minutes, and it sounds like you got your questions answered, but it's not necessarily a ton of time before a pretty notable procedure. So can you tell me a little bit about your experience with learning about this procedure and what the care team to educate you about deep brain stimulation looks like?
Yeah, it's not just Dr. Honey. He has a whole team of people. And so I spent a lot of time with the nurses. Nurse Nancy was my go-to, and she spent as much time as we needed. It was like several hours before the surgery together. And so I had total faith in the surgical team going into it. That was not my concern. I had two concerns going into it: my voice and staying alive. And you took care of my voice, and I took care of staying alive.
Yeah, there you go. Good teamwork.
And even during the surgical procedure, in order to test my voice, you'd say, Larry, say 4, 5, 6. And the first time I remember going 4, 5, 6, and you're like, oh, that's not good. Let's try something else.
Yeah.
And you're just moving it around.
Yeah. We have, I like to do the surgery with the patient awake, because when we can turn the stimulator on and see exactly what the results are. Are you getting a clinical benefit, or are you getting a side effect? And to me, if I was going to have surgery, I'd want the electrode in the perfect place for me. And I think that you can only do that with the patient awake, because you can test them and see. We are good enough now that we are often putting 3 test electrodes into the subthalamic nucleus, for example. And then we'll select which of those 3 is perfect. Any one of them would do just fine, particularly for the early, 3 or 4 or 5 years. But maybe later on in the disease, maybe 10 years from now, you're going to really want that stimulator turned up a little bit higher. And we want to make sure we're not close to any side effects like voice. And if we turn it up too high in that area, we can really strangle the voice and make it like Larry was sort of imitating, really hard for them to talk. There is a movement more recently, and some of my colleagues around the world are doing this surgery asleep, which is very enticing for the patient, because can you imagine? It'd be much nicer to just go to sleep, have your surgery, and wake up. We will be exploring that, but conceptually at this point in time, I don't see how it can be as perfect as doing it awake. It can be good, and for sure you can get the electrode in the subthalamic nucleus, but when we have 3 electrodes in and we're choosing the best one, I know that we have it optimized. So that's something I'm struggling with as we move forward, but because with the knowledge that you can have this asleep, the more patients are coming and saying, can I have it asleep?
Now, in Spain, you can get it done by a robot.
Yeah.
Is that true?
Yeah.
So how you advance the electrode is very center specific. I like to control the electrodes, but ultimately, I think that the hardest part of the operation is selecting the patient. So that is the art of medicine, selecting the right patient. Do they have the symptoms that would benefit from DBS? And if you did benefit those symptoms, would that translate into improvement of their quality of life? And that is a human understanding. No robot will ever be able to understand that. When you actually put the electrode in the brain, it's very sort of machine-like. We use an electronic drive, but you could have a robot do the same sort of thing. That's just placing the electrode.
So you mentioned earlier the experience of being awake can be overwhelming for some patients to even consider. I'm curious for you to share, what are the opportunities that are available to make that process of being awake a bit more easeful for the patient?
Yeah, so you can tell me about your experience, but over the years, we've tried to create an environment where it's less stressful for the patient. It's going to be stressful, but we try and make it less stressful. We have a nurse that is dedicated to the patient, so they're right in front of the patient, holding their hand and dealing with the patient. I like to put a live stream video of one of my favorite beaches in Hawaii up on the screen to just sort of take their mind away. We play music while we're doing it, and I think the tone in the OR is light, and I think the patients get a sense pretty quickly that these people know what they're doing, and Dr. Honey is relaxed. And it's a very relaxing time for me because no one's bugging me or asking me to do others. I'm just doing what I want to do. So it's actually, for me, the highlight of my day is when I'm in the OR because no one's bugging me. Yeah. Yes.
Not even the cell phone notification.
exactly.
If you could do something about the stereotactic
Pins.
pins.
Yeah. Yeah. So the most uncomfortable part of the operation is sort of putting the frame on, where we have to put local anesthetic in the skin and numb the skin. And we haven't found a way to put the local in comfortably. And it is symbolic, you're being locked into a frame that's going to hold your head still. And yeah, that's stressful for the patient. I appreciate that.
So Larry, can you tell us a little bit about, well, first, can you corroborate what you shared? Did you get the Hawaii wave?
Yeah, for sure. And I brought my own soundtrack and we played the Bee Gees.
Yeah.
Staying Alive.
Very cool.
Just for you.
Very clever. I do remember that.
You made a playlist, and I've heard on your podcast as well that you created an opportunity for other people to contribute to it. Is that cool?
Yeah. It is still there. People are still using it.
Where can people find that?
Oh, it's on Spotify. It's the initials of When Life Gives You Parkinson's. WL, I don't know. G-Y-P. And then it says the DBS playlist.
Perfect. And we'll drop a link for that in the show notes
Yeah.
as well so that people can turn to it.
Yeah, it's fun. And then like at one point, I think in the middle of the surgery, there was like 4 or 5 people just started belting out the Greatest Showman soundtrack. He's right. And you feel comfortable in there. I felt 100% certain that they knew what they were doing because I knew I didn't know what I was doing. And I was questioning my own sanity for some of that.
Yeah.
Like, how'd this happen? But for me, I think the great thing was Nurse Nancy being right there. I mean, that's so super important because whether you have an itch or whether you just need somebody to wipe your nose or whatever, I'm not allowed to move my hands up there. And then having just the tone of the operating room, I think is really, it's comforting. It is. You know you're in good hands. He's talking to you the whole time. Hey, Larry, here's what the drill sounds like. Here's what it sounds like when it's hitting your called.
That's a stressful moment for the patient because the drill, you can't actually feel the drill because there's no real pain sensors in the skull, but you can feel the vibration of it. And I always wonder, the dentist says this isn't going to hurt, and it always does. And so I worry that the patients say, oh God, Dr. Honey says this isn't going to hurt, but they're waiting for it to hurt. But typically there are no pain sensors there. So it's good.
I feel like once you push through it with 40 seconds.
Yeah, about 30, 40 seconds. Absolutely.
And then it felt like it was one came back.
Yeah. It must be a
It's
weird trying to imagine what that is. Yeah. But we do the operation through a small sort of dime-sized hole to lower the platinum electrode into the brain. And so we have to drill that hole in the skull.
I'm having a total moment here of being flooded back to my wisdom teeth being removed and how you can't really feel it, but there's something disconcerting about hearing it and kind of feeling around it.
Yeah.
But on a much more grand scale.
Yeah, I would say that it was not as traumatic as I expected it to be. And even the recovery was easy. I mean, I just hibernated for 10 days and slept and then got my stitches out.
Yeah. Did you leave hospital the next day?
Next day.
Yeah.
Yeah, easy.
That's our typical, come in the night before so we can get you off your meds and then have surgery the next day. Maybe start in the MRI at 7, start in the OR, 8:30, typically finished at maybe 2, and then up to the ward, sleep that night, CAT scan in the morning, make sure everything's okay, and then you go home at lunchtime the next day, usually.
Sure.
And then we usually leave the stimulator off for about a month or so. Then you come back in and see Nancy or Minnie or one of our nurses and have it turned on.
My honeymoon lasted 10 weeks, so they sent me back. They said, you're too good.
You're too good, yeah. So the electrode itself is a thin platinum wire, but if you're a neuron in the brain, it looks huge. And so when the electrode is put in and we hit the bullseye, the patient often gets a benefit, even with the stimulator off, because the cells in that area have been stunned from just the insertion. We call it an insertion effect. And so we have to wait till all that settles down and goes away and you're back to your baseline before turning on the stimulator, because we need you back to your baseline so that we can see, hey, when we turn on the stimulator, you get better. And then we know how much to turn on the stimulator. So that's what Larry's talking about, his honeymoon phase. It's basically an insertion effect from having the platinum hit the bullseye in the subthalamic nucleus.
Larry, something that you mentioned in our prior episode was that you need to go in for tune-ups, essentially. So you're going in once a year? Is that what you said?
Well, every 6 months now.
6 months.
But at first it was every week. Once they turned it on, the first day is they test the boundaries. So they take you through every setting. and see how far you can go before like you start seeing 3 of you, or before your tremor kicks in, or whatever it's going to happens. Because they want to see what the top and bottoms are for each of the settings. And then you go back the next week and they adjust a little more. And what they're trying to do is get you to wean you off your pills and turn up the electricity. So it doesn't happen overnight. It's like cranking it up to full blast. And so now, step by step, over the course between January 8th through February, every week I'd go in, and now I'm, weaning off the pills. So at first it was like they took maybe a couple of pills away, and then they took a couple more and a couple more. Now I'm down to a half a pill every 6 hours.
Because they don't know how much stimulation Larry needs. So it's a trial and error. So there's a fiddly bit. Hey, try this. Oh, wow, I'm better. Okay, try this. Oh, that's even better. Try that. Oh, no, that's not as good. Okay, let's go back to that. And so there's a fiddly part to try and find out exactly how much DBS would be optimal for Larry. And then you're hitting a moving target. So if he's really good today, he might not be good 5 years from now. And so in 5 years, click, 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 turn it up and chase the disease forever. Yeah, so it's not like getting your appendix out, we're done. It's like a therapy in lieu of medications. And you may increase your pills over time, or you might increase your deep brain stimulator over time to optimize. And if we get a side effect, you can back off. And so that's the strength of the DBS, is that it's adjustable after just one operation.
And the directionality of it is really cool.
That's new. The ability. It used to be just like a platinum ring, and the electricity would just expand out symmetrically. But now we can push the stimulation left or right or back or forward into an area where there's better response, and maybe away from an area that was causing a side effect. That's been a technical advancement that probably makes a difference.
When you spoke about our understanding of deep brain stimulation evolving over time, is the procedure evolving, and are there any innovations that are coming out that may impact Larry in one of his upcoming visits?
Well, the surgery's done in Larry. Hallelujah. We're in, out, no complications. So he's home free.
But the technology's in the battery.
Absolutely.
So when I have my battery replaced, and maybe I'll get new technology.
Exactly right. Yeah. So the battery itself just sits under the skin in the chest and probably won't last forever. And so there'll be a small operation to take that battery out and put a new one in. And every time a new battery goes in, there's the possibility of new technology. Yeah, absolutely.
So Larry, you shifted from medication to deep brain stimulation with medication as a bit of a supplement. Would you say that you experienced any of this transition in emotionality or personality after your deep brain stimulation and coming off of all of these medications?
No, I didn't have too much. My wife noticed some weird things. I'd get sharper. I might quick to trigger, but that went away as we adjusted. And, you tell the nurses what's going on, and you just have to track all this stuff, everything, because you never know what's caused by the deep brain stimulation and what's just normal. And they'll tell you, because I don't know for sure. For instance, I bump into things now, so I have less of an awareness of my spatial relations. And I've been told, and you can confirm this or not, that's going to improve as my neural pathways regrow.
Very likely.
Yeah.
Very likely. Some of our patients, we have to be very careful, because some of our patients come in wheelchairs, and they're deconditioned. They haven't been, walking well for 3 years. And you give them STN and they can go for a run. And I had someone die after getting his STN because he returned to running. He was a competitive runner in his youth. And he had a heart attack on an 800 meter, he was doing a master's challenge. And so, I was devastated. His wife said, he died doing what he loved. But nonetheless, he would probably not have died had he not had that surgery.
Wow.
But we didn't know that. And so now we sort of counsel our patients who arrive in wheelchairs for 3 years, you're going to be walking. You need to relearn how to walk. You need to relearn how to be aware of your environment when you're walking. And if you're going to be doing athletics, you need to go slow and gradually, don't just start an 800 meter sprint.
Well, and I used to use walking poles everywhere I went, because for balance and I haven't used them since the surgery.
Yeah. And so patients need to relearn how to walk because they've been adapting to their Parkinson's and doing different, clever tricks to try and get around without bumping into objects. And then all of a sudden we give them back a normality and it's, oh, what's that like? And so they have to, in a sense, physiotherapy and retrain their bodies how to move normally again. Yeah. But they have the ability to retrain their bodies. They knew how to walk normally before Parkinson's robbed them of that. And we give them the opportunity to relearn that.
And I think that's an important point is so many people who have Parkinson's who, as they lose things, they think they're gone forever. And for most things, you can get it back if you use the right therapist.
Yeah.
Like handwriting and stuff, like all that can come back.
Absolutely. But Parkinson's trains you to slowly give up because it's always taking from you. And it's never giving back. It's just taking. And so when you have surgery and you have the opportunity to get back what you've lost, you have to train for it. You have to work hard. Yeah.
One of the things that you asked me early on was, okay, so you're going to have the surgery. You're going to get back to base. What are you going to do with that?
Yeah.
I thought that was a great question. Like, what are you going to do with it? I'm like, oh my God, I'm going to play with my kid. I'm going to live life. And I am. Which is great. I've got energy for exercise now where I never had it before.
Can you help me understand? You're talking a lot about relearning, rebuilding new neural pathways. Where'd they go?
Yeah. So, good question. If you find out, let me know quietly, and then we'll share the Nobel Prize. Don't tell anyone else. You have one neuron connects to another neuron, and they're connections. And these connections are often pruned back. And when you are learning, you are increasing like a springtime on a flower, on a tree. You're budding and making these new connections. And so I think you're making new connections again and strengthening the connections that in the brain that work. More connecting than growing new neurons, we think. Although there's some suggestion that you can actually regrow some neurons. It's probably making, synaptic connections from one neuron to the next neuron and new pathways.
Well, and as the brain cells die, the dopamine brain cells die, you lose those pathways.
Absolutely. And Parkinson's specifically, there is a subtype of the brain cell, the dopaminergic neuron, that is dying. That is what's giving you the Parkinson's. And the brain is desperately trying to compensate by making new pathways. Yeah.
Interesting. And you mentioned Parkinson's. It sort of trains you to, what was the phrase you used?
Give up.
Yeah.
Trains you to give up. And dopamine is pretty central to motivation, yeah?
It certainly is. Yeah. Yeah, it certainly is.
Yeah. And by the time you're starting to show symptoms of Parkinson's, you've lost probably 60 to 70% of your brain cells.
Yeah, exactly. Even 80%. Yeah, the brain has a more than you need of many nerve cells as a sort of backup. And you actually don't really show symptoms of Parkinson's until you've lost the majority of those dopaminergic cells. Yeah.
So we're not replacing those cells, but with deep brain stimulation, what are we achieving?
Yeah, good question. So in the last 25 years, how deep brain stimulation actually works has been argued, and the theories have changed. As we get more and more information, we realize that they're just theories, that the theories are probably wrong. I can tell you what the current theory is, which might be good for the next 10 years. So who knows, or might be the truth. Your heart has specific rhythms, and if it has a good rhythm, it functions really, really well. And if you have an abnormal rhythm, your heart fibrillates and you have a heart attack. So in the brain, there are certain rhythms where the circuits of electricity moving through the brain, and there are certain rhythms that are particularly bad and interfere with your movement and are like putting on the brakes. And the DBS inserts electricity into this circuit at a very different rhythm and jams that bad rhythm and allows a more normal rhythm in the brain. That's the current theory. And
well, but it makes sense because now they're creating actual playlists for people to listen to that will change the way you walk, that will help you with your tremor. And
it fits our current knowledge. So For example, a Parkinson's patient, if they're humming a tune or dancing with their wife, they might be able to move remarkably well. As soon as they stop, or as soon as they come to a doorway, then they freeze and stiffen up, and one wonders if different rhythms going through the motor circuit in the brain are facilitating and inhibiting movement. And what we're doing is we're jamming the inhibiting rhythm in the brain.
So, as somebody who's not in the medical field, I have this curiosity around why we're able to get to a point where we find solutions but don't know what the root of the problem is. Do you have any insight on how we got to a point of understanding that deep brain stimulation addresses these problems?
Yeah, so truth is, the vast majority of big discoveries in medicine are absolutely by chance, by people who recognize that, wow, that was a significant, but weren't specifically trying to address that problem. The discovery of penicillin, he just noticed that there was mold and around the mold, there was no bacteria. Oh, there must be something in the mold, penicillin, that kills bacteria. Oh, boom, antibiotics. And then, the discovery of insulin. There are so many examples.
Levodopa.
Yeah, levodopa, absolutely. And then the surgeon in Grenoble in France, Alain Benabide, was a notable neurosurgeon doing thalamotomy like everybody else, but had been given a new piece of equipment that enabled him to stimulate at a slightly higher frequency. In the old days, the machine would go to 50 hertz, and you would use 50 hertz to test out, am I in the right place in the brain, before you burned a hole in it and tried to get rid of the tremor. And he was given a machine that could go to 100 hertz, and he thought, well, why don't I try 100 hertz and see what happens? And all of a sudden, the tremor stopped. So high frequency stopped the tremor. Low frequency at 50 drove the tremor, right? It was closer to that pathological frequency. But he went up to 100 hertz, and all of a sudden, the tremor stopped in front of his eyes. And he was smart enough to think, well, maybe we could put an electrode in there, stimulate at a high frequency consistently, and then DBS was born.
So I'm curious, you've got a really solid care team that you've brought together. What advice would you give to clinicians as they're building out their team? What do you think is the most important to achieve to set the patient up for success?
Oh, wow. Yeah, it's so many little things, but one of the key factors would be choose good colleagues. I've spent a lot of time and support for our team, and I think we have a really good team. It's the nurse, Nancy, that's getting you through the OR while I can focus on what I'm doing. And she's making the patient comfortable and able to get through, the operation. I couldn't do it without her. Collaborate with a good neuroradiologist. You want spectacularly good imaging of the brain to see exactly where their blood vessels are so that you can plan not to go through them. And good imaging translates into reduced complications. And there are so many aspects come together, but we train 1 or 2 neurosurgeons a year from somewhere around the world, and they come and they see our system, and then they go back home and they implement our system because they've seen, one that works. And so we have 30 neurosurgeons around the world doing the surgery that they learned in Vancouver.
That's cool.
Yeah. Thanks to patients like Larry. Absolutely.
We need more.
Yeah.
We need a lot more.
Yeah.
And something that really stuck out for me is that it sounds like your family was in the room with you during your procedure.
Not during the procedure, but in between the MRI and the procedure, I hung out with them, and my son held my hand and wiped the blood from the frame off my face.
Oh, gosh. Yeah.
Yeah, it's good.
For me, one of the most important things during the surgery is the planning of the surgery, right? Measure twice, cut once, as every good carpenter will tell you. And so we're trying to select the target, which is the subthalamic nucleus. You hit the target, you get a good result. You miss the target, you get a poor result. But then the electrode has to go from the outside world to the target. It has to traverse the brain. And if it traverses the brain and doesn't hurt a blood vessel, you'll have no complications. And we take a lot of time between that MRI and actually starting the first skin incision to plan exactly how the electrode would be optimized for this individual patient. And we tailor the surgery to that patient's neuroanatomy, and it'll be different than anyone else's.
What did the planning phase look like for you, Larry?
It looked like I was looking at the ocean while he was in the back one is due.
Yeah. We're trying to make it boring for them, right? The planning is done when your family was with you, a lot of that. And then when you come into the OR, we're just doing our best to sort of take you away from exactly what's happening. There are some patients who are asked, what are you doing now? Where was that? Why is that? Is that a good thing? And then we try and please, if possible, just focus on the nurse and the ocean lapping the beach, and I'll get you through this.
I got so bored I fell asleep.
Yeah, some patients do. And they usually have a crappy night's sleep the night before because they're, they're worried about it. So they're tired.
And off their medication.
Yeah, and off their medications. And then in the OR, if the OR can become boring, they can, believe it or not, and the patients can fall asleep. Yeah, and we let them sleep, and then we'll wake them up for the part that we really...
Larry, we need you now.
And planning, I more so mean for life afterwards. So, you've got a plan to get the procedure, and then thereafter, did you have to take time off of work? How long did it take you to adjust?
Yes, I took time off work, but I took permanent time off work. My work ended the Friday before my surgery, permanently. So I had no time frame that I had to deal with. I was on my timeline, which was great. And then I could do what I wanted to do, and I started my own nonprofit, and that's what I do now, called PD Avengers. And then my wife and I had to figure out, okay, so now that we have Larry back, what responsibilities can you pick up? And she's going to work now, so now I have to take care of the household duties and whatnot. So that type of stuff had to go on. But for the most part, you're just preparing you don't know what to expect. Like, I didn't know what effect it would have on me, good or bad or otherwise. So once you realize, oh, wow, I can do a lot of stuff here, then you begin to add more to your plate.
Tell us a bit more about PD Avengers.
Yeah, PD Avengers was created during the pandemic. Started with the book called Ending Parkinson's Disease that was written by Ray Dorsey and Michael Oken and Todd Shear and Boz Bloom. And the organization itself is a patient-led organization. We have 150 partners worldwide. We have 7,600 members, and we are in 98 countries. We are looking to add urgency to the cause of ending Parkinson's disease. And anybody can be a PD Avengers. Just go to pdavengers.com.
Wonderful. Well, thank you both for being here today. This has been incredibly illuminating. I'm curious if either of you have any final words that you'd like to share that we haven't covered yet today.
Oh, wow. I'd just like to say thank you to Larry for being so brave to allow us to do the surgery. I can't imagine how brave the patients are, but I must say I really enjoy the operation. So I have a wonderful day when I'm in with our patients, and I thank you for being so brave.
Thank you. I appreciate that. It takes a lot of discussion with your spouse and with your family to get to the point where you're ready for it. And you have to prepare for it. Yeah, I had to get a will. I had to get all that in order just in case. Because anytime you have surgery, there's a possibility that it's not going to end right. And so you're thinking about that, and then suddenly, boom, it's day of, and you're like, okay, here we go. And thank you for your unshakable hands.
What a joy. Yeah, my pleasure.